Chapter 1. Hepatic Hydatid Disease, Echinococcus. Introduction and definition. Hepatic Hydatid disease, also known as echinococcus, is a parasitic infection caused by larval stages of tapeworms belonging to the genus Echinococcus. This disease primarily affects the liver, which is the most common site of cyst development. The two main forms of echinococcus impacting the liver are cystic echinococcus, C, and alveolar echinococcus, A. Each form exhibits distinct pathological, clinical, and radiological features, necessitating different approaches to diagnosis and management. Etiology and life cycle. The disease's etiology involves complex interactions between definitive hosts, intermediate hosts, and humans. Carnivores such as dogs and foxes serve as definitive hosts harboring adult tapeworms in their intestines. Intermediate hosts include herbivores like sheep and cattle, which develop cysts after ingesting eggs. Humans become accidental intermediate hosts through ingestion of eggs via contaminated soil, food, or water. The life cycle begins with eggs releasing oncospheres in the duodenum, which then penetrate the intestinal wall, enter the portal circulation, and predominantly localize in the liver, where they develop into metacestodes or hydatid cysts. Classification and staging. Ultrasound classification for cystic echinococcus C. CE1, unilocular, simple cyst with uniform anechoic content, may show the water lily sign if the germinal layer detaches. CE2, multiseptated cyst with daughter cysts, resembling a honeycomb pattern. CE3, cyst with detached endocyst and or solid components, indicating degenerative changes. CE4, heterogeneous contents without daughter cysts, representing degenerating cysts. CE5, calcified, solid-appearing cyst wall, indicating inactive disease. P&M classification for alveolar echinococcus. P, hepatic mass ranges from P1, peripheral, to P4, vascular extension. N, adjacent organs N0 or N1. M, metastasis M0 or M1. Pathophysiology and disease mechanisms. The pathophysiology varies between C and A. In C, the cyst comprises three layers: an outer host-derived pericyst, an acellular laminated membrane, and an inner germinal layer responsible for producing protosclerosis and daughter cysts. The cyst enlarges gradually, exerting pressure on surrounding tissues. Conversely, A exhibits an invasive, infiltrative larval mass that proliferates through exogenous budding, forming necrotic microvesicles without a limiting membrane. This behavior mimics malignancy, with potential for local invasion and distant metastasis, especially to the lungs and brain. Clinical manifestations. Features of cystic echinococcus. Many patients with C remain asymptomatic for years. Symptoms typically arise from the mass effect of enlarging cysts, including abdominal pain, discomfort, and hepatomegaly. Complications such as cyst rupture into the biliary tree can cause obstructive jaundice and cholangitis. Rupture into the peritoneal cavity may lead to anaphylaxis and secondary dissemination, while infection of the cyst can cause abscess formation. Features of alveolar echinococcus. A often remains asymptomatic for 5 to 15 years. When symptoms develop, they resemble those of liver malignancies, including epigastric pain, weight loss, hepatomegaly, obstructive jaundice, and ascites in advanced stages. The infiltrative nature of AE can lead to significant liver destruction and metastasis. Diagnostic approaches. Imaging modalities. Ultrasound is the primary diagnostic tool, useful for initial detection, staging, and follow-up. CT and MRI provide detailed information about cyst number, size, location, relation to vasculature and biliary structures, and complications. A lesions on CT/MRI appear as heterogeneous, infiltrative masses with irregular contours, necrotic areas, and clustered microcalcifications. Serological tests. Serology, including ELISA and immunoblot, aids in diagnosis, but has variable sensitivity and specificity. For A, specific antigens such as M2 and M18 offer higher sensitivity, up to 100%. FDG PET imaging can assess metabolic activity, especially in A lesions. Differential diagnosis. Conditions to consider include simple hepatic cysts, cystadenomas or cystadenocarcinomas, abscesses, hemangiomas, primary or metastatic hepatic malignancies, and polycystic liver disease. Management strategies. Cystic echinococcus. Medical therapy. Benzimidazole such as albendazole, preferred, and mebendazole are used, especially in inoperable cases, multiple cysts, or as prophylaxis before surgery or percutaneous procedures. Albendazole is administered at 10 to 15 mg/kg/day. Contraindications include early pregnancy and cysts at high risk of rupture. Percutaneous treatment pair involves puncture, aspiration, injection of scolicide, e.g., hypertonic saline, and reaspiration. Best suited for CE1 and CE3A cysts larger than 5 centimeters. It offers a minimally invasive alternative to surgery. Surgical options. Goals include parasite inactivation, cyst removal, and cavity management. Conservative procedures involve cyst unroofing and omentoplasty, while radical approaches include paracystectomy and liver resection. Laparoscopic surgery is increasingly common in experienced centers. Watchful waiting is appropriate for inactive cysts C4 and C5. Alveolar echinococcus. Radical liver resection is the treatment of choice for resectable disease, often requiring complex biliary reconstruction. Liver transplantation is considered for unresectable cases or severe liver failure, with lifelong albendazole therapy post-transplant. Long-term albendazole is essential for disease control, primarily parasitostatic. Complications. Intraoperative spillage can cause anaphylaxis and peritoneal dissemination. Postoperative complications include biliary fistula, biliary stricture, sclerosing cholangitis, cavity infection, and recurrence. Prognosis and follow-up. C generally has a favorable prognosis with appropriate treatment, requiring long-term ultrasound and serological. A has a historically poor prognosis if untreated, but shows improved survival with combined surgery and lifelong antiparasitic therapy. Lifelong follow-up is mandatory for AE patients. Key numerical data and thresholds. Scolicidal agents like hypertonic saline require contact times of approximately 6 minutes. Larger cysts and those with biliary communication pose higher risks. Laparoscopic procedures have a morbidity rate of around 15%, with a conversion rate of about 5%. Recurrence rates are approximately 10% for conservative surgery and 1% for radical surgery. PARA is indicated for C1 and C3A cysts larger than 5 centimeters. The median growth rate of A lesions is approximately 14.8 milliliters per year. Guidelines and evidence-based practices. The WHO IWG classification guides treatment decisions, emphasizing a multidisciplinary approach, especially for A. Benzimidazoles are indicated for inoperable C and as lifelong therapy for A. Surgery remains central for complicated C and resectable A. Percutaneous methods like PARE are validated minimally invasive options for specific cyst types. High-yield clinical pearls. The water lily sign indicates detached germinal membranes in CE cysts. Calcification, especially microcalcifications, is common in AE and indicates involution in C5. Ball staining of cyst fluid is an absolute contraindication for scolicidal injection. Omentoplasty is preferred for managing residual cavities post-surgery. Postoperative biliary fistulas are best managed with ERCP and stenting. A exhibits invasive, metastatic behavior, often termed parasitic cancer, requiring lifelong antiparasitic therapy. PNM staging is crucial for prognosis and management in A. PARA is suitable for C1 and C3A cysts. Chapter: Liver tumors and related conditions. Definition and overview.